Good evening, aspirants. Today's class is on psychiatry, MRCP, and it will be taken by Dr. Hassan. Sir, I hand over the class to you. You can begin the class.
Let's go with the lecture. First, we need to know what is hallucination. Though I know that all of you know about these hallucinations, but a little bit you need to know so that you can clarify the diagnosis actually. What is hallucination actually? It is a sensory perception which is that occur in the absence of external stimuli. So external stimuli will not be present there. No, there will be nothing else. Just patient will declare you about his experiences. Like I can see some tigers, I can see some sort of instruments, I can see some sort of anything, any objects you can see. So this is very much important one. So there are some features you should clear about hallucination. That what is the difference between hallucination and the imagination? Can anyone tell that imagination and hallucination, just how you can, make a difference between these two things? Imagination, we can all imagine with ourselves. No, you can imagine a dream and anything else. But what is the difference between this hallucination and imagination or dream? There is some difference you can see. Like
We have
hallucination.
insight, like we know
Yes.
that we are imagining.
Yes. Yes. Very nice. That is yes, and also you can do anything with your imagination. Like you can imagine what you are favorite for. Like you like a player from your country, so you can imagine him, no? And you can imagine your mother, your father, all of them. But the hallucination, you cannot be imagine as yourself you want to, because it's a disease. That hallucination is not normal. That's why I'm saying. So look, the characteristics: perception without external stimulus. There would be no any object. There would be no object, and then you can see that vivid and clear. The experience is real and it is clear, and it is involuntary. That is the important thing. Imagination you can imagine at any moment. That is voluntary, but it is involuntary. This is very important. Involuntary perception. So sometimes they would not describe you in the scenario that it is hallucination. They would describe it as a involuntary perception. You should be clear in your mind that is a hallucination. If you don't understand the question, you could not go for the answer. So involuntary perception is known as hallucination. If any question, in any question you can see, that is not real, unreal things, but patient seems it is real. Patient can tell you that it is real. Occurs in any sensory modality, like visual, auditory, mostly auditory hallucination, visual, and another tactile. These three is very important for us: tactile, visual, and auditory. No, visual hallucination, anything he see that other people don't see. Auditory hallucination, anything he hear, other people don't hear. So anything you sense, other people don't sense. So these all are the things about hallucination. So this is very important. I think you will just go for the reading these criteria, then you can understand very easily. Next, go to the these are the descriptions I just described here: auditory, visual, tactile, olfactory, gustatory. You should know about this term. Auditory means hearing sounds and voices, someone whispering in your ear. So you can just hear it by two sounds, three sounds, a lot of sounds you can hear. Then visual, seeing objects, people, patterns that are not there. Tactile, feeling some sensations in touch and pressure. Tactile hallucination is very important to diagnose a disease like alcohol withdrawal. We will come to these pathologies. Alcohol withdrawal symptom, one of the features, that is tactile hallucination patient will feel. Some insect crawling around the beneath the skin. So insects, you will feel insects beneath the skin. So you can find that is tactile hallucination. Mostly it is alcohol withdrawal. Other things, there is some amphetamine induced can happen. Olfactory smelling odors that are not present, okay. Gustatory tasting things without external stimuli, okay. We know the we know these pathophysiologies and these terms. Now we will go for the third person hallucination. Do you know what is third person hallucination? First person, second person, third person. Very, very important for us is third person hallucination. Just read it here. I have described it. That third person hallucination is an auditory third person hallucination. Yes, it's an auditory third person hallucination in which an individual hears voices speaking about them like anyone. He or she tell you, like you are just having a discussion with your friend, that you are telling that he asked me to do this thing. Who is he? This is third person. Who is she? Or any type of objects, or any someone. You can tell it someone. Someone says me that I have to do this, or I am the king. Someone told me that I am a king. So someone whispers in his ear that he is a king. So this someone is third person. This is third person hallucination. They will tell you in the scenario that someone tell him that he is a king, and it is whispering in his ear. So it is third person hallucination. This is pathognomonic, and this is very important for which disease? Schizophrenia.
Schizophrenia.
Yes. So you have to identify from the from the question stem that what is third person hallucination. They will tell you that this someone tells the patient that he is a king, or he is going to die, or any bizarre things. But the voice, that is a voice. You should keep the mark that is a third person voice. A third person voice. Just a third person voice. Okay. So now we know about the third person hallucination. Whenever I just repeat these things, you will understand that this is a third person hallucination. So it would be easier. Often associated with schizophrenia. Now there are some hallucinations came in exam, that is haptic hallucination. Very important one. Haptic hallucination. Haptic hallucination. Sorry. Haptic hallucination. Haptic, you should know the term. Look, insects are crawling beneath the skin. This is one of the tactile. This sensory tactile hallucination also, but it is known as haptic. Haptic, haptic hallucination. Most common in alcohol withdrawal symptoms. Again, cocaine abusers, amphetamine abusers also can see, and schizophrenia is also can do that. But very, very important one is alcohol withdrawal. This is very important. Whenever you found that, you should go for the alcoholism, whether the patient is alcohol dependent or not. Then you can answer it as a alcohol withdrawal syndrome. So haptic hallucination, they sometimes can write in the question that haptic hallucination is present. So if you don't know the haptic term, you will be in danger, or you will be in difficulty. So haptic hallucination, you should know the term. Again, another one, hypnagogic hallucination. Hypnagogic, hypnopompic. Transient hallucination, visual, auditory, tactile, occur when patient going to sleep. This is part in sleep disorder. If you are going to sleep, then you can see some hallucination that is transient. This is hypnagogic. And there is some sleep disorder where hypnopompic hallucination. It is at awakened moment. Whenever patient is awake, then he can percept. This would be a transient. Patient will recover spontaneously. So these are the term of hallucination we know now. Let's go. Delusion. What is a delusion? You all know about delusion. There is a lot of talks, but we need to know the which one. It is a false belief only. Only these things, if you know, then it will be easy. It's a false belief. So it is not normal. False belief. That is not evidence. That is not that can be contrary to any information. That can be resistant to his cultural terms. So anything else, just a delusion is important. Psychosis. Important part of psychosis, no? Delusion and hallucination, these two. So let's go. You will read it in your other time. Now, what are the types of delusion? You need to know about the types of delusion. Look, here, this is very important. One of the type, that is delusion of thought possession. Thought. Sometimes they will give thought insertion, sometimes thought withdrawal. There is a thought. that thought possessions delusion can happen. Anyone being controlled uh, by anything, like he could say, the patient could say you, told you that I have been controlled by this alien. So that is external force. This external force is forcing the patient. So this is a delusion. Alien could not forcing his legs or arms like that. So this is type of delusion, that unrealistic talks. So that can causes delusion. Okay. So delusion of thought possession, like what are the thought possessions? That thought insertion, thought withdrawal, thought broadcasting. These three important features are very important for schizophrenia. And you know that thought insertion means any belief that being placed the person's mind by external source. He can say the external source could be a robot, could be his supernatural force, could any technological device like mobiles. So these all are the things we will be in the scenarios. So we will come with the scenarios, then we can very easily deny it. The person feels that, look, one of the example here, person feels that these thoughts are alien, do not belong to them. The thoughts are alien also. So this is thought insertion. Thought withdrawal, that object or that alien can uh, just deny his mental content or his mind's thinking. Suppose you are thinking that you want to go for the playing football, but the patient is saying that I could not play football because the alien reminds me not to go. So this is thought withdrawal. So something unreal, something unrealistic, we need to understand. Thought withdrawal and thought insertion. Thought broadcasting is same, that someone is hearing my all thoughts. That is thought broadcasting. So someone is hearing all the things. Someone is reading my thoughts. So this is thought broadcasting. Just you would know by having some reading here. So now participatory delusions, there is grandiose delusion. You know, grandiose, very important. Grandiose means I am the king, I am the big person. So I know all the things. This is grandiose. So grandiose delusion of grandeur. This is most common in case of mania. There are some common things which are most commonly, can be a feature of any disorder. So grandiose delusion is a feature of mania. In mania, if there is any psychosis, mostly these patients suffer from grandiose delusion. So you need to understand. And delusion of possession like thought insertion thought, that is schizophrenia. Schizophrenia mostly delusion of possession or reference. Delusion of reference. Reference means any kind of robot, any external force is forcing you not to do this or have to do this, or they are reader of your mind. The external source is a reader of your mind reader. So this is delusion of reference. So delusion of reference is schizophrenia. Delusion of grandiose is from mania. So you should remember these things specifically. Then it will be very easier. Believe me, it will be easier. Erotomanic delusion. Erotomania, you can see that someone in higher in love with the person. So that is erotomanic. So it's easy. Somatic delusion, the belief there is something wrong with the body, being infested by parasites. So that is somatic delusion. These are very easy things. I think now this is the time you can read. Any one of you can read. What is this? Dr. Deepasri or anyone?
No. A 30-year-old old man with schizophrenia has been walking around wearing a mental helmet and has covered all his windows with tin foil. Sir, can you hear me?
Yeah, I am hearing you.
Okay.
Yes, it's clear.
Okay.
Thank you.
Then covered all the windows with tin foil. He reports that this is to stop his thoughts leaking out of his head and being read by others around him. What is the
Yes.
symptoms called? Auditory hallucination, thought blocking, thought broadcasting and thought echo, thought withdrawal. Okay. So
Mind reader. Mind
yes,
reading. Mind reader is broadcast. Something
yes,
broadcasting.
thought broadcasting.
Yes, thought busting. It is one of the common thing in schizophrenia. Schizophrenia. So thought broadcasting will be answer. What is thought blocking? You are reminding of you have something to do, but he
Yes,
is not.
but cannot express.
Yes, cannot express. Yes, by why cannot express? Because he reports or anyone just misleading him. Misleading him. That is
Yes.
the thing. Okay. Thought withdrawal.
Okay.
You are thinking of something, but he is not.
Uh-huh.
He is not going to do. He is not give you permission to do that. That is the thought
Yes.
withdrawal. So these things is very little thing, but you need, if you understand, that would be easier. So let's go now.
Thought blocking is our.
Thought blocking, yes. The mind, your mind will be stopped. They will stop you
Yes.
to give you any speech. That is thought blocking.
Yes.
Okay. Here are some descriptions I have provided in this lecture so that you can read it because it is part of your syllabus. That's why I'm giving it. If you read my whole lecture, I think you will pass 100 by 100 in MRCP part 1. Even MRCP part 2, you can do good. Here are some delusion experiences. Look, delusion of reference. Believe that a special meaning lies behind something innocent, public domain, songbook, newspaper, TV. Delusion of guilt. No, it is delusion of references. It is not guilt. Guilt is guilt. Guilt, we know about the guilt. Patient is feeling guilty. That is guilt. That's why I am not giving this elaboration. Delusion of reference is these all the reference actually. This thought insertion, thought blocking, thought broadcasting, thought echo. All of these are references. Nihilistic delusion. Negative belief of oneself. Yes, fully negative thoughts, like any depressive patient having delusion, that is nihilistic delusion. Okay, a depression person, what are the depression signs? Depressed mood, low mood, eating poorly, eating heavily, neglecting herself, cannot sleep, hypersomnia, excessive sleep. So all of these criteria are depend on the are involved in the depression. So in case of depression, if a patient for the depression having delusion, that is named as nihilistic delusion. That is negative belief that I am worthless. That is a negative belief. That belief is a delusion. And he will talk with you with the confidence that I am a negative person. So that is nihilistic delusion. Okay. So this delusion is important. What is obsession? Obsession. How you can describe obsession? Obsession is a repeated senseless thoughts that causing you repeated working, like hand washing. You are imagining that you have soil, you have some dirty germs in your hands. This is a thought. This is obsession. And compulsion, what is? You are going for the work, regular washing your hands in the shower for 1 hour. This is compulsion. So obsession, compulsion, repeated work that you could not deny. So this is also involuntary sometimes. Your mind is preoccupied by your obsessions. So if mind is preoccupied by obsessions, that is obsessive compulsive disorder, OCD. Very, very important to know. A lot of questions over there with the obsessive compulsive disorder. Okay. We will describe it here in the lecture. Okay. Let's go. Now, schizophrenia, why it is occurred? Why schizophrenia occurs? There are no other things. Actually, there are older neurotransmitter theories. There are a lot of theories actually, but newer theories like this. This is the newer theory. Look, the newer theory. This is important. Glutaminergic neurotransmission, hippocampal aspartate receptors. You need to know this only. Memorize this actually. That hippocampal problems are going to face this schizophrenia patients mostly. So this is unknown why this is happening, but there are some risk factors to happen like this. So this is very important. Some structural changes you can see in MRI, that is hippocampal, parahippocampal area, thalamus area, temporal gyrus, frontal lobes, all of these areas are important. So we have to know the green zone is the question zone. Okay, this is a question. You need to know. Older theory, there are some neurotransmitter problems, and newer theory, there is some problem with the glutaminergic neurotransmitter hippocampal area, that is me, and methyl D-aspartate receptor. So you need to memorize it only. Let's go. Next, epidemiology. Just you read it, in which early to mid 20s and late 20s in women can suffer from schizophrenia. So A, B, C, D, you can learn with the A, B, C, D, or you can learn with D, H, D, D. So these are the mnemonics, or you can, if you understand, I think no mnemonics needed. So there would be a delusion, that is delusion of reference mostly, and thought insertion, thought broadcasting, thought removal, withdrawal, thought echo, all of these are present in the schizophrenia. Okay, now you know, all know about these things: thought insertion, thought withdrawal, thought broadcasting. These all are the delusion. Okay, delusion of reference, as I told you earlier, the delusion of reference. These all are the things, delusion of reference. If they said in one term, that is delusion of reference. So these are thought insertion and blocks. Hallucination, now you know which third person hallucination. Now you know that hallucination, that is third person hallucination, will be a external stimulus will having whispering to your ear. You can see in some movies like these problems patients suffer. So now we can go for disorganized speech. Can be happen sometimes, disorganized speech. Negative symptoms. You know the positive symptoms. What is the positive symptom? These two are positive symptoms. Whenever the positive symptoms you think, that is delusion and hallucination should be come here in mind. And negative symptoms, patient is blunted, apathetic, that is blunted effect, apathetic, poverty of speech, poor motivation. Like a silent person is like negative symptoms. If you are talking with one person, that person is remain silent and no speech uttered, so you can say you are very negative. So by this thing, you can just memorize those things. He is very negative. I have asked a lot of questions, but he's apathetic and he could not answer anything. So it is something that is pathological, you know. But you will treat which symptom? By positive symptoms you will treat. And we have read in previous lecture, positive symptoms treatment are which drugs? Antipsychotic drugs. You know the mechanism of action. Antipsychotic drugs mostly effect on the positive symptoms, not on the negative symptoms. Little negative symptoms will be helpful with the atypical antipsychotics, but mostly we will treat the patient for the positive symptoms, because delusion hallucinations are very dangerous. Patient will go to suicide after this. So that's why these are the very severe, that positive symptoms. But these negative symptoms would not go for the let him go for the suicide. You know, negative symptoms, patient will just more poorly motivated and poorly. But positive symptoms, if a patient suffer, he will just go for the suicide. That's why we need to treat it. This schizophrenia is very dangerous. You should admit that patient is diseased. You should treat it. Okay, let's go for the other. There are some differential diagnoses. So psychiatry is a disease of exclusion. Whenever you just exclude the other organic disease, then you go for the psychiatric diseases. No. So look, Snyder's first rank symptoms may be divided in. Schizophrenia is very important. That's why I have repeated it a lot of times. Auditory hallucination, thought disorders, passivity phenomenon, delusion of perceptions, that is reference. So all of these things are will come in your minds, that auditory hallucination, thought disorders, passivity phenomenon, delusion of perception. These delusion are associated with the thought disorders. Same. So you will read it by yourself, these criteria. I will not describe it right now. Let's go for the next slides. What are the other features? Yes, I have told you. Now I want to tell you one thing you need to understand, that is impaired insight. Do you know what is insight? What do you mean by insight? Insight, yes, please.
But
It's just to understand.
able to know the exact fact.
Yes, able to know the exact fact. Right. Absolutely. That is, you know that you are a diseased person. This is insight. I know that I am a diseased. I have diabetes. So I know this. So this is my insight. I have a heart disease. I know this. This is my insight. But the schizophrenia patient will not know that he is a diseased or he or she is a diseased person. This is impaired insight. So lack of insight, this is very important part. You can find some questions. A lack of insight, which part of this? Very, very important. That is schizophrenia. Schizophrenia, lack of insight. Okay. So there are some hallucination occurs where insight is intact. What is the exception? Everything come with the exception. So is there any insight intact but hallucination present? Any example do you find? Insight intact, but patients suffer from a lot of hallucinations. You have read the ophthalmology. Did you complete the ophthalmology, your batch? Eye lectures? If you are not, then you will not be familiar.
No.
Okay, so the insight is intact, but there is hallucination. That is known as Charles Bonnet syndrome. Did you heard about this, anyone? Charles Bonnet syndrome, CBS. Charles Bonnet syndrome. Yeah.
Charles Bonnet.
Yes, he's not blind actually.
Macular problem.
Yes, there is macular degeneration. Yes, a patient can have blindness after complications, but yes, there's for that disease, patient will suffer from some hallucinations. That is Charles Bonnet syndrome. So actually, this is very important because some hallucination over there, but insight is intact. In that disease, the difference is the insight is intact. The patient will know that yes, I have some problem in my eye. That's why I am seeing this type of things like flowers, like any other thing in any other areas. So that is Charles Bonnet syndrome. We will come in that scenario. Okay, now what are the treatment? This is schizophrenia treatment from 2009. It is similar right now. That is oral atypical antipsychotic are the first line. What are the names? Olanzapine, Colanzapine, no, they are the names. So you should read those names, okay? That was described in previous lectures. So all of these things are atypical and cognitive behavioral, CBT therapy you will give. Cognitive behavioral therapy, CBT. When you will give CBT, if patient is not tolerant to the antipsychotic, if there is any side effect, any refractory, and patient going to suicide, and then you should detain him and you should give him cognitive behavioral therapy. So any advanced stage and all patients should go for the cognitive behavioral therapy. If in any scenario they will give you that patient suffer from DKA, or patient uncontrolled diabetes, having high glucose, what will you give? You will give CBT first line, because atypical antipsychotics will increase the glucose. That is a complication. So it's an emergency that DKA or diabetes mellitus is uncontrolled, then patient will suffer a lot of complications. That's why you will then first line will be CBT, cognitive behavioral therapy. So you should be in mind that what is contraindication, what is the indication. Very much important. So first line, last line, we know. Suicide of patients, schizophrenia, 10% patient die, and 50% patient, no, look, 50% patient, this is a lot. Sorry, it's going 50% patient. Okay, now we can see 50% patient are going to having 50% attempt to suicide. No prognosis, there is some prognosis 10 to 50% good and bad prognosis. Prognostic factor is very important to remember, memorizing. Look, describe these things. Within this one line, you can remember these poor prognostic factors. If you read this one line repeatedly, young abusive male with abnormal personality had gradually strong family with no precipitant, low IQ with social withdrawal symptoms and has neurological signs, substance abuse history. So this is a line that is a poor prognostic factor line. So you can remember it anyway, but you should remember that a young person who is a male and who has abnormal personality, who has low IQ and substance abuse, he has family history and absence of obvious precipitant. So all of these things have poor prognostic. This is very, very important. Poor prognostic, it is, you should remember in psychiatry class. What are the poor prognostic factor for this schizophrenia? In any way, you should remember it. So sometimes we read this line that young abusive male with abnormal personality, graduate a strong family with no precipitant low IQ, having social withdrawal and has neurological signs with substance abuse history. So total line you should remember, or otherwise you have to remember all the charts. So this is the important poor prognostic factor. Mostly came the family history and the young male with low IQ. These are the mostly came in questions, like absence of their precipitant, family history. This is important more. Low IQ male. These are the important factors. You can remember only. Let's go. Now, what we have understand, we will implement with the question. Anyone?
A 34-year-old man presents to the emergency department complaining that he has had an electrical chip inserted in his head, which is giving him great power and sending him messages that I am the one. He also claims that his legs are moved by the great force. These experiences began about 9 months ago, but only became troubling in the past few days. He appears slightly perplexed and concerned. However, he is settled and sits quietly in casualty while awaiting further assessment. What is the most likely underlying diagnosis?
Yes. You can see a lot of term bipolar disorder. You know the bipolar disorder from previous problems. Bipolar means patient could be manic or hypomanic, mania plus you can say depressed. Both of these things come into the bipolar symptom. So any mania or depression over here? No, I think no. Cotard syndrome, it is a one kind of delusion with the dead body, something like that can be. Drug-induced psychosis, organic psychosis,
No, schizophrenia.
schizophrenia. So what are the schizophrenia finding you can find here? Look.
Thought insertion.
Here, he also claims that his legs are moved by great force.
Great force.
This is something that is
External. Third
yes.
person.
Delusion of grandiose.
No, it's not grandiose.
No, it
Someone
is-
is moving his leg. So this is
Third person hallucination, sir.
hallucination.
There's a
yes.
thought insertion.
Yes, it's a thought. It's a thought.
Yes, thought insertion.
Thought insertion. Someone going to do a motor work. So that is thought. And what is the actually hallucination is the perception, you know, that is not a motor work or any type of work. There is a perception giving him great power. Someone is giving him great power. Another thought insertion is here, electric chip is inserted. This is also thought insertion. There are many insertions over there. Thought inserted. This is thought insertion, giving him great power. Sending him messages, I am the one. This is messages, I am the one. This is the, you know, this is the hallucination. Where is the hallucination? Messages that I am the one. Hallucination is the message or whispering in the ear. Yes, you can say also. You can also say that is delusion of grandiose. But grandiose with the mania mostly. They gave it here because to give you some problem that you can say that there is some mania. If you find depression, you will tick mark the bipolar disorder. They give you some little tricky areas. But messages that I am the one, it's a message, it's a hearing message. So this is very important to know that it is hallucination also. And another thing you can find, because delusion of reference is the part of reference or delusion some other form, not grandeur mostly. Okay, so you can say like that. But if you feel any kind of thought inserted or thought echoed, then you should go for the schizophrenia. That is I am telling you about. That complaining that he has had electrical chip inserted in his head, which is giving great power. This is thought insertion. Mostly, this is thought insertion. Okay, now you know. And another thing is legs are moved by force. Legs are moved by force. So these two are very important for the schizophrenia. No organic, no drug-induced, Cotard syndrome not present. Bipolar and schizophrenia, you will suffer a lot if you are read a lot. that you read, you prepared a lot, that's why you can suffer a lot with these things. But you should go for a straight one, that it is a thought insertion. So I go for schizophrenia. No more discussion, just go for that. There's so then you can answer it. Okay, I think that would be easier. Look, the positive findings here. So auditory hallucination is keeping saying that he's stupid or he's the boss, he's the one. So that is here is auditory hallucination actually. And electrical chip, that is thought insertion, and his legs is removed. This is also thought insertion. There is two thought insertion actually here. Or you can say passive experience. His legs are moved by any other one. This is a passive activity. So passive experience can be happened in the schizophrenia. So this is very important. Now this, anyone just read it rapidly so that we can memorize now schizophrenia. Anyone?
You review a 17-year-old man who is brought to the emergency department by the police. He has been arrested for assault and claims that he was told to do it. Which of the following clinical features in the psychiatric history is most strongly associated with schizophrenia? Lack of insight, restlessness, withdrawal from social contacts, insomnia, panic attacks during social interaction.
Lack of insight.
Yes, you're right. Very important, and you all know about these things. So your insight will be absent. That is the important one. This is very important one, I think, to know. Here all are the features are here. Just read it rapidly, or whether you can find it or not. No need to read the investigation, only read the scenario. We could not hear. Is there anyone reading? Okay, I am just reading it so that you can understand. Look, on examination, you first go for the on examination. No need to read on examination. What do you find? Am I audible? Hello?
Yes, sir.
Am I audible? Okay.
Yes.
So this is another thing that on examination he looks disheveled. He's wearing silver hat underneath his clothes, attempted to cover parts of skin and fall. He looks like washed for some time. On further question, he tells you he believes that he is being controlled by the government. What is this? He is being controlled by the government. This is thought insertion, or anything is thought. Transmitting microwaves which are controlling his mind. All of the controls and thoughts. This is thought control of thoughts. You can say that is thought inserting or anything else like that. They are inserting voices in his head which tell him to do things. Inserting voices in him. This is also insertion, including attacking his mother who is a spy. So if you find any thought insertion, then you will go for the schizophrenia. There are some other external features here. You could read it. It is a schizophrenia. So this is a big picture of schizophrenia. You will read it and you can understand it. Okay. So this is another schizophrenia. Look, there is they can read her thoughts via telephone and the television, and their silver foil partially protects him from this. This is an abnormal thinking, and believes he is being controlled. So anyone being controlled, that is a problem. Voices in his head which tell him to do things. This is a hallucination. So auditory hallucination, any controller like thought controlling, or any type of thought insertion, all of this present. So it is schizophrenia. Okay. I think if you read it, then you can understand it very easy. Let's go. The big picture I should not give. Okay, now this is little. Anyone can read it. Which one would be suggestive that is schizophrenia? Depository, you can read.
Sorry, a 22-year-old man is found in the street by the police and brought to the emergency department. He is semi-naked and has been approaching passers-by in an agitated fashion. Which of the following statement by the patient most strongly suggests the presence of schizophrenia? All the police in this town have been spying on me. Okay, I have been given special power by God. Sorry, lost, sir. কোথায় গেল
Yeah.
রে বাবা? Sir, I have lost it. Just wait. I'm just
Okay.
coming from this phone. I am doing this. Just wait.
Okay.
Oh, just wait, sir.
By the time if anyone read, you can give the answer. For schizophrenia, which will be true.
Option E, sir.
Yes, very nice. That is E. What is this? The voices control me. The when we take my clothes off. So this is third
Yes.
person.
The voice control. They made me take my clothes.
This is hallucination.
Third person hallucination.
And look, this is type of delusion of grandeur. No, something like that. Some false belief, someone give his to eliminate these things. So special powers. So that's why this is most important. The third person hallucination you need to understand. Okay, let's go. Voices control. Okay.
Sir,
This is,
can you explain why this is more specific?
which one? Which one?
Last question, delusion of grandeur, and there is another options, right? So why we are choosing the option E?
Because that is third person hallucination. That is a pathognomonic for our disease, the schizophrenia. That's why there are a lot of disease that can correlate with other options. So we need to focus on the disease. We need to understand. Look at this. You can find some explanations there. If you find that all the police in this town have been spying on me, this is some other kind of problem, like paranoia. You know, this is something paranoia, that they are spying me, they are doing things. So paranoid are not kind of schizophrenic. There's the things. That's why you need to know that which one is most common in schizophrenia. So paranoia is not within the schizophrenia. Okay, so this is paranoia. This is paranoid delusion. All are these delusions actually. Which one is hallucinations? This is hallucinations. Okay, now you understand.
Yes.
Then this is delusion of grandeur. Delusion of grandeur. So delusion is really a danger thing actually. That can give you some false belief about hallucination. You could not understand where is the hallucination, where is the delusion. So that's why you need to go for the voices. Someone speaks, someone's voices, someone tell you in the mind. These all are the things as auditory hallucination. So you need to know, just read it carefully, that whether there is any voice, any mind displaying things. That's why you need to ask. Okay. So in schizophrenia, now you know that third person auditory hallucination, the passive movement by external force, by the thought insertion, thought echoing, thought controlling, all are the things which can causes schizophrenia. No, so this is very easy now. Now,
can I read it?
Yes, you can read it.
The lady loses her husband.
A bit loud, please.
Yes, a bit louder, like them.
Yeah.
If you are louder, then it is easier.
A lady loses her husband.
Yes.
At a road traffic collision.
Yes.
3 months afterwards, she says she regularly hears his voice when alone at home.
Yes, her voice.
Yeah, she is not eating very well.
Okay.
She lost 5 kg of weight at this time, and she never sleeps after 4:30 a.m. in the morning. She says she often feels his presence around her and sometimes sees him when she goes outside. She is reassured by these feelings. What diagnosis would you suspect? Is it an adjustment disorder, psychotic depression, post-traumatic stress disorder, hypomania, bereavement reactions.
Look.
Reaction.
I have done a equation. Look, I found the hallucination over there. I found depression over there. So
Yes.
hallucination, you know that is termed psychosis.
Psychosis.
Yes.
So if you just do join
Psychotic
this two,
depression.
yes, this is one of the important thing that can bring you in problem. That is psychotic depression. So what you need to identify whether in depressed patient whether hallucination present or not. You need to identify the hallucination one. That's why I have started my lecture with the hallucination. You need to understand what is hallucination actually in the scenarios. Then it will be very easier. By mathematically, you can understand the diagnosis. So be very careful and just understand whether the depression symptoms are over there or not to identify the psychotic depression. So what is the treatment? Will you give you the antidepressant here first for this depression?
Antipsychotics first.
Yes.
Antipsychotic.
Why? Because patient will go to suicide with the psychosis. So prevent suicide, you should treat it, this depression with the antipsychotic.
Antipsychotics.
Then you can go for the depression treatment. So this is psychotic depression. Now you found here, where is the hallucination is here. So in every patient where you just read the scenario, you should find out the hallucination one. If you find the hallucination one, you can answer the option, whether it is schizophrenia, whether it is any psychotic depression, whether it is mania, any type of hallucination present in anywhere. Okay. So like mathematics, you can answer it. Look, she says she often feel his presence around her, sometimes sees him when she goes outside. This is one. Another one, here's the voice. No, here's the voice alone at home. One is visual, another is auditory. Very important. Wait a minute. Okay. All right. So now.
So can you please explain why the other options are not fitting into the answer?
Okay, you can see that adjustment disorder is a type of phobias. Okay, so you cannot adjust with your within the room. So that is a adjustment disorder. In post-traumatic stress disorder, we will come in soon. There will be no hallucination. No hallucination. PTSD, it is a stress disorder. There will be no hallucination. Patient will suffer from intense panic attack or any type of intense physical symptoms, but there would be no repeated nightmares over there. Hallucination and nightmares are different. Nightmares, night dreamings. That's why dreams, imagination, a lot of imagination of the same things, that accident or abuse. You will imagine that's why I am telling you that hallucination and imagination, what is in first word, I just tell you about the difference. What is imagination? What is dreaming? Why dream and imagination? That is, you can imagine. And that child abuse patient or that post-traumatic stress, like any accident he faced. So that patient will, what will he see? He will see that thing. That is a nightmare for him. That is the imagination for him. He can imagine it repeatedly. And pathologically, if he imagine, that is post-traumatic stress disorder. There will be no hallucination over there. Adjustment, it is a phobic disorder. Hypomania. In hypomania, you read it, flight of ideas, patient with irritability, patient having extra energy, like psychomotor agitations. These all are the features of hypomania. Not in, if they said in mania can be hallucination occurs. But in hypomania, it is opposite to the depression. You know that cycle, that is happy cycle and sad cycle.
Yes,
depression is in the sad cycle. Hypomania in the happy cycle, more happy. No, more happy. So
Yes.
it could not be present here in depressed. This is a depressed patient, alone at home. She is very much missing, never sleeps, never eats. So this is a depressed. So no hypomania cycle. And bereavement reaction is a grief reaction. You are sad. That is grief. You know that sad cycle, the grief reaction, that is physiological, not pathological. So all of these things are not, only the present one is psychotic depression. I think now you can understand.
Okay. Yes, sir.
Okay. So it's mathematical, no? Now you can understand that it's mathematical. The mathematically you can diagnose.
And sir, when
Yes.
hallucination is present, all those are to be ruled out, right? Hallucination
Yes,
occurs in
yes,
psychosis only.
yes, you are right. You are right, very easily. That's why you need to find out in the scenario what hallucination. Do you find the hallucination here? Yes. What are the hallucination? Here sees voice, who is already loses. No, he's no more. He's no more. Loses her husband, but he is hearing her his voices. So hearing voices, it is auditory hallucination. Patient, he lost his husband. There is no husband. So, but where, how here, that is hallucination. Another thing, he sees him. Sometimes sees him go outside. How he can see her, him? So this is hallucination. You need to understand actually these two things. This is not something grief reaction. This is something hallucination. So psychotic depression, you should treat this patient. Otherwise, patient will go to suicide. Patient will be in emergency. This is an emergency, you know. The psychosis happens, you should treat it. Otherwise, patient will go for suicide. So as a doctor, we should know these things also. So let's go. They also elaborate it here. So I will give you the lecture. You can read it before you go for the any question bank, so that you can understand side by side. Okay. Now you know the Charles-Bonnet syndrome. Did you heard it? I have told you about the things. That is Charles-Bonnet syndrome. Very important. Charles-Bonnet syndrome. This is persistent and recurrent complex visual auditory hallucination. Look, visual and auditory occurring in a clear consciousness. Is insight, good insight, against background of visual impairment. So this is very important. 15 questions are there in the past test that with the CBS, Charles-Bonnet syndrome. So it is very, very important to understand, identify, because in ophthalmology and also in psychiatry department, it can. So that's why it's important. You must absent in other disorders. Patient should be with age-related macular degeneration, glaucoma, and cataract. So the age-related problems is this advanced age. You know the multiple myeloma? In multiple myeloma never occurred in the young age. You know the 10 years, 15 years. Like this, also this age-related macular degeneration and this Charles-Bonnet syndrome never occur in youngers. It will be above 50 years or above 65 years. So patient in scenario, you will find that patient is elderly, like 65-year-old gentleman having this type of problem. So you can exclude it very easily. Like other things like CML and also multiple myeloma, these are not occur in the young patients. Okay. So like this age factor is very important. So advanced age, peripheral vision impairment, social isolation, sensory deprivation, early cognitive impairment. This is also important. Risk factor is very important. Yeah. Treatment, no treatment, reassurance. Because his insight is okay. He will not go for the suicide. He knows that he has this problem. So these hallucination are benign hallucination. Because patient know, look, the emergency. In schizophrenia, that is a emergency because patient is not known that I have disease. But here, look, there is no treatment, only reassurance. Because this is benign disease. Patient has good insight. I know that I have this problem, so I don't need any treatment. Very easy treatment now. Now one of you can read it very easily. 82-year-old female.
Yes.
Yes. Please read it. Please.
Who has glaucoma?
Yes.
Experience visual hallucinations.
Yes.
Include seeing
Goldfish. Yes.
boxes and mudsliding downstreams. She is
Blind.
in
Okay.
the right eye.
Yes.
Partially sighted in the left eye.
Now it's easier, no?
Yeah. Yes.
Charles-Bonnet.
Yes. I will not describe it now. You all understand. Very nice. Let's go.
What is Anton, sir?
Yes. Any question?
What is the Anton syndrome, sir?
There are a lot of syndrome actually. Anton syndrome is brain damage syndrome. Occipital lobe problem can cause sometimes a problem. That is Anton syndrome. There will be no hallucination over the syndrome. That is Anton syndrome. Actually, in neurology, there are a lot of syndrome, but they will give you those are commons. Okay, so this is another thing. You know now the causes. I will just give you age-related macular degeneration. No, this is the answer most common. This is most common number 1, number 2, number 3. So answer is age-related. Same If you read it, then you can understand easily for which visual hallucination insight is intact. Age-related macular degeneration. Okay, this is something that is delusion will come in favor, but here this is important thing because it is a common thing that you have Prime Minister is secretly in love with her. So any kind of like Salman Khan or Shah Rukh Khan is love with him or her. This is a syndrome, no? This is delusion. Just reading, you can answer it. Decrumble syndrome. Okay, there are some syndrome in one line. You can find in any notes that one line you can just read it. That's why I'm giving here. There's all delusions are over here. Look, the decrumble syndrome, some delirante syndrome, that is acute psychotic, where hallucination, delusion, perception disturbances, variable changing day to day. Just know these things. There are no question about that. Fregoli delusion, Capgras delusion, just you need to read it. COVID, so some somatic symptom in the pregnancy, during the pregnancy, but there is no recognized basis. So you should read the line only, then you can answer it. Sometimes it can, sometimes don't can. So not to describe it more. Now another difficult one, that is personality disorder. Whether the patient having personality disorders or not, all look like similar. If you read the scenarios of personality disorder, you will be in very much difficult position. So to just do it as a very easier things, I am having just giving some lecture about the clusters. If you know the clusters, you will know the personal disorders. Look, the cluster. There are something that is similar in the personality. So that similar thing you need to identify first from the scenario. Okay, from the scenario you need to find the cluster. Look, this is cluster number A, this is cluster number B, personality disorder. Now we are reading. Okay, this is cluster number C. So in every cluster, why they have made it as a cluster? Because there is something similar, all of them. In cluster A, look, paranoid personality disorder, schizoid, schizotypal. These are the similar, mostly similar, not all, but the mostly similar you need to identify from your scenario. Then you can answer very easily. So mostly similar, first you will identify from the scenario, then you will go the individual one. Then you can answer it, okay? Again, this paranoid, this schizoid, schizotypal. This is personality disorder cluster number A. You need to identify whether I am just finding that this finding is present or not, okay? Look, paranoia means suspicious. So everyone here will be suspicious to other works. They will have a suspicion. No, shandeho bole etake banglaয়. So this is doubt. So the doubt, patient having doubt or patient's relatives have doubt about them. So there will be a feature of doubt over there. So you will find, whenever you find suspicion, you will come to A, cluster A first. Then you will specifically, individually, you will go for the characters, okay? Then you can answer it. Otherwise, you will miss the personality disorder, okay? Then in cluster B, how you can understand cluster B? Cluster B is a criminal. You can just say that cluster B is a criminal. This is a criminal cluster. Antisocial, you will kill anyone, a killer. Borderline, it's like a crazy girlfriend or a crazy boyfriend. I am not racist, so I am just giving both examples. A crazy girlfriend or a crazy boyfriend. That is a borderline personality. A histrionic is a attention seeker. A attention seeker is not a good person also. So attention seeking condition having antisocial activity. And narcissistic, you know that Hitler, that is narcissistic. So it's also killer. So attention seeker, girlfriend, boyfriend, borderline personality like killer, all of these has similar cluster B. So now if you find any kind of antisocial or any type of harm to the patient or to have behavior of the patient, that is cluster B, then you will go the individual one, okay? I think that would be better like mathematics. And the C1, that is avoidant. The term is itself called that he is avoidant. He avoid all other men's, women's, all of them. So he is very avoidant. And also dependent. Avoidants are also dependent to one person only. And very anxious. They are obsessive mostly. They want to work so perfectly. So a perfection. They seek perfection mostly. They will seek perfection. All of them will seek perfection, but will not be successful. They will be unsuccessful. So these criteria, if you find, you will go to the C, cluster C. Then individual, we will read, and then we can answer, okay? So first ABC cluster you have to identify from your scenario. Then you will go for the individual job. Then you can easily answer, okay? Paranoia means doubt, suspicious. Schizotypal, same. Schizoid is like Batman. A Batman is solitary personality. He has no sex, no sexual attraction, no other emotional activity, no love. Only he will do activity. He has only activity, solitary activity. He will save the mankind. He will save all of the colleagues. There's the solitary person is schizoid, but he's very suspicionful. So he has some doubting capabilities. Okay, so that's why it's very important having this problem to identify. Let's go. Now it's easier if I going to the table. If you go for this table, then you can memorize it easily. Look, cluster A. Okay, I think if anyone just read it about this thing, then that would be better. So any doctor can read it from cluster A, paranoid.
Suspicious, secretive, self-importance,
Yes.
hypersensitive,
Okay.
litigiousness. What do
Yes.
you mean by that?
I don't think so. I don't know.
Argumentative, inclined to dispute or disagree, preoccupied with conspiracy theories.
Yes, this thing is very important. There is some conspiracy for me. There will be some conspiracy. So you can come to cluster A. Then you will go for these all things. He is very hypersensitive. He is very secretive. These are the things only that you can answer. Now read it. Schizoid. This is Batman.
Solitary activities, lack of partner or sex, no effective praise or criticism, emotional coldness or detachment, marked insensitivity to social norms.
He is not social. He came to night. No, he came for the night, and he's the night rider like Batman. So you know all the facts. However, you just imagine the Batman, you can answer it. But there is some social norms problem. Okay, he can think that there is some conspiracy about his town, about his land, about so there is any suspicious things with the solitary activities is schizoid. Now these things, please read. Schizotypal.
His suspicious, eccentric behaviors, thinks people judge him unfairly.
Yes.
Paranoid plus ODD behavior.
Odd. This is odd behavior. Odd behavior. Yes.
Odd thinking, odd speech, odd belief, bizarre fantasy.
Now you all know that all are the things similar, but there is some solidarity, some lack of emotion, that is schizoid, and other things are conspiracy theory, that is paranoid. Schizotypal is odd behavior, odd thinking, odd speech, odd belief. If you read this oddness with the paranoid, then it is schizotypal. You will answer it, okay? If you find anything odd thinking, odd behavior, odd speech, odd belief in the scenario, and also paranoid phenomenon, that is suspicious phenomenon or conspiracy theory, these two plus, you will go schizotypal. Only the conspiracy, you will go for paranoid. And there is Batman-like feature, you will go schizoid. Very easy. Now I think you will answer it easily. This identity disorder, okay? First come to the cluster, then go for the imagination, like imagining Batman, imagining other men. Now let's go to the cluster B. Please read the cluster. You can read it, okay? You have read it well. That's why. Cluster B.
Antisocial.
Yes, I have given some mnemonics. I have given some mnemonics so that you can remember it, okay? And dissocial.
Aggressive, not social, deceptive disregard, repeated lies, impulsive and incapacity to learn from experience or incapacity to experience guilt, substance abuse overrepresented in prison, consistent irresponsible, irritable, incapacity to maintain enduring relationship, attack others, lack empathy, callous unconcern for the feeling of others, blame to others.
This is a lot, but if you read the antisocial manner, this is a killer, actually a killer. You will just read that any kind of killer is antisocial. So it's a killer, a killer. So killer is antisocial. You know, he is a criminal. A criminal goes to the jail. They will say it in the scenario. So that is very easy. You can find antisocial. So something is criminalism over there. Now read the borderline one. This is very important, borderline. You can easily imagine it. Okay.
Stable, unstable, stable, imagine abandonment, feeling empty, quasi psychotic thoughts, strong
Yes.
family history of mood disorder.
Yes, quasi psychotic thoughts means the psychosis, actually hallucination, hallucination, visual hallucination about relationship. You will see that his boyfriend or his husband is going for another one. So that is a quasi psychotic thoughts. Okay, now go.
Unstable, self image, prefers stay at home but hates being alone.
Yes.
Intense, short lived emotional attachments, frequent self harm.
Yes, this is dangerous. Patient can go for suicide. So this is very dangerous. Patient can go some unstable mood, stable mood. In a stable mood, this is actually happening with the cycle. There is a cycle of a stable, unstable man in borderline. That's why it is borderline. Sometimes he is imagining, then he is going for action. Imagining and going for action. This imagination have some psychosis also that he or she thinks of. That's why I'm saying this is girlfriend and boyfriend. As he and she are very suspicious. No, not suspicious. They are very, that imagination that he will abandon him. He will not with him. So at that moment, he will harm himself or herself. So that's why it is borderline personality. Okay, now let's go to the next one. Histrionic, attention seeker. No, app in the drama. The monkey in the drama. That's why app in drama. So histrionic means attention seeker. Read it, please.
Attention seeker, continual seeking for excitement and appreciation. P, provocative. E, excess emotional and flamboyant. I, inappropriate sexual seduction. Dramatization, self.
Yes, this is also, this emotional thing that is very dangerous, but you need to go for the attention seeker. If you just go for attention seeking, then you can very easily just thinking that that this is something like this history. But inappropriate dramatization self, this is also important. Dramatization, he will make a drama and having excess emotion. And flamboyant means he has some behavior that have some attraction. We will produce some attraction type of behavior. So this is flamboyant. Okay, so this is very important. He or she will be in very stylish mood to having attention seeking. So this is flamboyant. So F in drama, A for attention seeker, P for provocative, some provocation can be happen, excess emotion, inappropriate sexual seduction, drama. He will make a lot of drama. This is histrionic. Okay, AF in the drama. So now narcissistic is very easy as Hitler one. Just read it. Hitler is the
highly self-admired, inflated sense of self-importance, taking advantage to others, lack of empathy, arrogance, aggressive, ruler or sense of grandeur.
Yes, that is Hitler. So these all are the things. One thing you can identify here, that all of these patients are antisocial. All of these patients having some problem with lack of empathy. They have no empathy about their selves and also for others. So lack of empathy, if you find, you will come to the cluster B. Okay, then you will individually go for the scenarios. So these mnemonics also, I think, very easy to remember. Okay, AP in drama, stable, unstable, antisocial, Hitler. So you can just go for the mnemonics repeatedly. Now the avoidant. Read it, please, rapidly. The cluster C, who are dependent or avoidant, both are similar.
Avoidant, fears criticism, overly serious, withdraw from work, personal risk, socialism, shy, inferior, always feel inferior.
Yes, is very shy, is very fear, withdraw from work, any work. Just these things are avoidant. No dependent.
Dependent, indecision, encouragement of others to make personal decision, inability, feeling to care for themselves, lack initiative and unwilling to make demands, extensive support from others and fear of losing support, subordination of their needs to others.
Yes, they only wants the supports. That's a dependent. And another one, the obsession. This is OCD. Obsession.
Perfectionist with no completion of task.
Yes.
Rigid, stubborn, aggressive, unwilling to pass the task to others, feeling of excessive doubt and caution,
Yes.
excess consciousness
Conciseness.
and scrupulousness.
So this is OCD. This is one kind of OCD. Obsessive compulsive disorder is obsessional. So he will not complete the task, but he will repeatedly doing the things, but he will not successful. So this is OCD, obsessional, dependent, avoidant. So all of these are cluster C. Okay. Now you can remember it by these boxes so that you can understand all the features. Now let's go for one scenario so that you can understand which one is this.
Is there any difference between OCD and the personality of?
Yes, mood disorder. Sorry, we cannot hear you.
Is there any difference between OCD and
yes,
personality?
OCD and
obsessional personality. Does it come under?
No. There is. This is one of the example. The obsessional personality has the OCD. Okay, similar. You can combine them. Anyone can read it if you can identify it.
Yeah, a 23-year-old man.
You need to be louder. I think
yeah.
You can take the mic so that everyone can understand.
23-year-old man presents to the emergency department, having been brought in by police. He says that his wife has been unfaithful on multiple occasions, such that he has lost his temper, punched her, and slashed her face with a bottle. She admits that she has been punched and kicked multiple times over the past 4 to 6 weeks. He says he hasn't slept for the past 2 days because his wife has been away with another man. Says he did the right thing and won't be charged as he has friends in the police force. His wife says that his allegations are not true and she seems to be a reliable witness. He has no past medical history of note. He smokes 20 cigarettes per day, drinks 8 pints of beer per week. Clinical examination is most likely diagnosis. Clinical examination is unremarkable. Which one of the following is the most likely diagnosis?
Paranoid.
Yes.
It's a paranoid. Yes.
No, I have write it. You find that suspicion over there. Now,
No.
which cluster it is?
A, cluster A.
Yes. Now you will go for the individual one. So you can easily, wife deny it. No, allegations are not true. So he is paranoid mostly because you can find cluster A Batman here. There is no Batman. Schizoid personality, it is not present. So only paranoid over there. And there is no odd thinking, odd behavior, odd other things, odd speech. Nothing is like that. Clearly paranoid phenomenon is present. The suspicions theory, conspiracy theory, suspicion, doubt, paranoid. So paranoid personality. Very easy. I think they put only cluster A here. So that is more easy.
Yes, sir.
How they can make it difficult? If they in hypomania they give it schizotypal. No, then it would be harder, more harder. Whether you are thinking of odd thinking, odd speech, odd behavior, all of the things not present. So it would be more difficult. That is MRCP 2. Now you are in MRCP 1. That's why they provide in cluster A. So very easy, I think. Now you are going for the clusters. So you will go first cluster, then you will go for the answers. Okay. Let's go the other things. You can read it easily. Oh, now we have to go. Yes, this is very important. Go for rapidly. Yes, you can read.
A 28-year-old Christian leader who lives alone says she does not have any friends and thinks that people judge her unfairly. He says that the power of crystals will cure leukemia, and sometimes feels that a life story appears in magazines. So, what is the best description of a personality? Borderline, histrionic, paranoid, shy-shot, and psychotype. Schizotypal.
Yes.
Judge her unfairly.
Schizotypal.
Schizotypal.
So odd thinking. You should think about odd thinking. Okay. Is there any suspicion you find? Sometimes feel that her life story appears in magazine. So this is kind of suspicious thing that she's thinking. Any doubt thing it feels that life story is in magazine. So this is not real also. So odd thinking with the suspicion over there. So that is schizotypal. I think now you all know very easily. Schizotypal, paranoid. Now this one is important. One another. Read it rapidly again.
27
Very important.
27-year-old unemployed man is referred to a GP for investigation of hematosis. He describes a history of fluctuating mood dating back to his late teens, chronic feeling of emptiness, and repeated deliberate self-harm by cutting. He occasionally uses cocaine and cannabis and admits to occasionally drinking up to 10 pints in a day. He confides he has recently been arrested for hitting his most recent girlfriend after she threatened to leave. He is angry for having had to wait 20 minutes before seeing you in outpatient and storms off when he has to wait for blood test. What is the most likely diagnosis?
Borderline.
Yes. So you find some jail and other words that is you put on the criminal mind. That is cluster B. In cluster B, all are the criminals, no? Hitler, narcissistic, all are the criminals. And there is some girlfriend things threaten to leave him. There is something, imagination, there's leave him. And also he is feeling empty, repeated self-harm, no? That is unstable one. Unstable one. Here the stable one. Imagination to leave him. Imagination of leave him, no? So these all are the things that cluster B. Now you find the borderline. Yes, this is borderline.
Sir, why it is not antisocial personality disorder?
Yes. Why? Because in antisocial there would be real criminal, no girlfriend over there. So you have to thinking about some strange thing about girlfriend, boyfriend. Believe me, this would be present in borderline personality.
Yes, substance abuse.
Yes.
Habits.
Yes.
And, he has been arrested for eating his most recent gun eating, probably antisocial behavior.
Because there is fluctuating mood. That's why it's borderline. You know, there are a lot of fluctuating mood. A lot of criteria are there not having antisocial, because antisocial will be a killer, only a criminal killer. He will stab someone. But here he's arrested hitting his most recent girlfriend after she threatened to leave him. Hitting, not killed. If antisocial is very dangerous, okay, he's the criminal, he's the killer, and here he is a boyfriend girlfriend issues. So that is borderline. And also there is fluctuation. If any fluctuation over there mood, you should go for borderline. Okay, that's why I think. Okay, I think now it would be easier. Otherwise, it is very dangerous one. Okay, so last one. This is something other things. I put it from the child's book actually. So it is attention deficit hyperactivity disorder. This is something you will read. That is, you will not find any kind of other personality. ADHD. Okay, you will read it after if I provide the lecture then. Okay. Let's go to the psychiatric. I just provide it due to understand that ADHD could be possibility, because there is a baby whose examination is normal, but he's forgetful, he's irritable, he has no memory sometimes he's having annoying with parents. So all of these things are ADHD, okay? Attention deficit hyperactivity disorder. So this is some kind of personality also. So now we will go for anxiety disorder. I think personality disorder, schizophrenia, mood disorder, thymia, you all will know very easily if you go for the recordings also. You will go for this class recording again so that you can understand my each word, okay? Now, anxiety disorder. Do you know that which disease can cause anxiety? You first exclude the anxiety diseases if you are in medicine ward. So what are the diseases? Hyperthyroidism, paroxysmal arrhythmias, pheochromocytomas, hypoalcohol, benzodiazepine withdrawals, hypoglycemia, temporal lobe epilepsy. These are the organic diseases. You must need to exclude, no? Must exclude for anxiety. So you need to exclude them also from the scenarios. Whether patient having any organic problem, that would be organic causes. So if you just cross them, then there will be mind disorder, though normal response to threat. General anxiety disorder, panic disorder, phobic disorder, okay? So these are the general anxiety disorder. Am I audible?
Yes, sir.
Okay. So now you know the diseases. So you need to exclusion. You need to exclude the disease. You know, in the PACES, when you are going to the final part of the PACES, they will give you the stem. This patient suffer from anxiety. Please collect the history, do the examinations, and go for the diagnosis. You need to exclude this one. Otherwise, you will fail. If you not exclude the hypoglycemias, alcohol withdrawals, hyperthyroidisms, paroxysmal arrhythmias, otherwise you will fail. Because you need to exclude the diseases, organic diseases. Without organic problem, you could not treat them, no? So organic diseases need to be excluded. Then you will go for, yes, this is a general anxiety disorder. We need to go for anti-anxiety drugs or reassurance or counseling. So that's why, okay? So you need to know the anxiety disorder. You need to exclude from the scenario also, whether there is pheochromocytoma or not. You can find some panic attacks with the pheochromocytoma in the scenario. Do you know the pheochromocytoma? You heard it about in endocrinology. This patient is suffer from which? Fluctuating blood pressure.
Headache, fluctuating blood pressure, headache, palpitation.
Yes, palpitations. These three triad, very important. With this anxiety, a lot of anxiety over there. Then the diagnostic point, you know, the metanephrine, 24-hour urinary catecholamines, you will do CT abdomen, you will do MIBG. So a lot of things after that, okay? So if you find any anxiety in the stem, you should go for whether pheochromocytoma are present or not, patient is alcoholic or not, there is hypoglycemia or not, thyroid problem or not, okay? So you need to exclude it because you will not give the exam for psychiatry. You will give for whole medicine. No, you don't know the scenarios, whether it is psychiatric or not. So if that in anxiety attack or in panic attack, if you find any kind of sweating, chest pain, then it is MI. This is acute MI. So for general anxiety disorder, I have to tell you, you need to exclude the disease one. Then you can understand the general anxiety one. Look the scenario. A 24-year-old student feeling on edge all the time, feels that nothing specific makes him feel worse. So nothing specific make him worse. He cannot relax, sleep well, his appetite is good. He tells that his mood is okay. So the same symptom all of the time, same symptom, but nothing specific make it worse. But he is not good. So that is general anxiety disorder. So this kind of scenario will be present. Only a young patient feeling on edge all the time is not good actually. He said that I am not well actually, doctor. But there is nothing specific that make me worse. I cannot relax also, but I can sleep well. I have good appetite. My mood is okay. So this is general anxiety disorder. Now you can understand. You have to exclude other organic things. Then you can answer the general anxiety. So the pathognomonic word is same symptom all of the time. Same symptom all of the time. That I am not well. I am not so much relaxed. These will be in the scenario. Okay. Some mnemonics I have provided here. That is MRI of mind, sleep, and concentration. MRI, that is muscle tension, restlessness, irritability. MRI of mind, sleep, and concentration. So that you can understand that each words are important to memorize in case of general anxiety disorder. Otherwise, you will just thinking of the words, which word is for general anxiety disorders. That's why I am just remembering by saying MRI of mind, sleep, and concentration. So you will be difficult in concentration, disorder in sleep, sometimes sleep well, fatigue, irritability, restlessness, muscle tension. So these are the things can come in the general anxiety disorder. Before that, you need to exclude the thyroid, you need to exclude the pheochromocytoma, you need to exclude the MI, you need these things. Okay, let's go. This is the box for general anxiety disorder, panic attack, and phobic attack. All are the similar things, but the differentials will be on the organic causes. So look, chronic anxiety, uncontrolled worry, muscle tension, bowel disturbance, sometimes sleep disorder, persistent symptom, agitated, worry things. And panic attack is what? Chest pain, palpitation, paresthesia, lips and fingers, dizziness, sometimes escape behavior. He will not tell you about the behavior. So involuntary hyperventilation. Do you know the hyperventilation syndrome? That's
Yes.
now involvement here in the panic attack and also in the OCD. So they divided the hysteria that in two diseases. They divide it and they update it. In a panic attack, there is hyperventilation also, and in OCD, obsessive compulsive also, there is hyperventilation. So these two are parts of hyperventilation syndrome. So you need to, there is no hysteria now. Now term is changed actually. So you can easily just understand these things by reading. Okay, these are the panic attacks. There will be tachycardia and there will be paresthesia, all of the things, involuntary hyperventilation, episodic fear. But you have to exclude the MI, stroke, and other things. Okay, then you can understand this is panic attack, general anxiety. And phobic disorder, there is some phobia like needle phobia, flight phobia. Then you can say that crowded place phobia, that is agoraphobia. So you just need to remember these things. No need to understand this. This is very important. Agoraphobia is very present, and this is common. Manufacture phobia and flight phobia also. So they will avoid all the areas. They will avoid. Okay, so it's easy. Let's go. Treatment is same. You will go for reassurance. You will for cognitive behavioral therapy. You will go for the just SSRI. You will go for paroxetine and SSRI. You should remember. Okay. Anxiety disorder, SSRI, early antidepressants are leading point. No benzodiazepine should not be given. Sometimes beta blocker can be given. Look, OCD disorder, obsessive compulsive disorder, you will read it only. That is obsession causing compulsion. Okay, I just want to here just describe you one thing. Do you know the difference between action and impulse? What is the difference? Action or impulse? Both are similar.
Impulse is impulsive. That means this.
No resistance.
Yes, no resistance.
Yes, there will be no resistance. You will do it. Suppose I am just giving you example. You want to slap one person you don't like. In impulse, you will slap him. There will be no resistance. But in action, you will think, no, I would not do this in this area. Okay, in this popular area, I will not do these things. That is action. I think now you can understand. So that is impulse. So this compulsion is acting like impulse. Impulsive behavior is the compulsive behavior. That's why I am telling you. He could not resist it actually. There's the thing in the scenario. You're not resisting. You will do it repeatedly. It is OCD. Okay. So it is depend on depression disorder. It is one kind of depression disorder. It is one kind of anxiety disorder. Also, it is one kind of eating disorder. That is anorexia nervosa patients also can have this problem. And Tourette syndrome, you will read it in the neurology. Tourette syndrome, you know, the abnormal motor. The film, there is some with the Vidya Balam, that is Hitchki, I think. That is Hitchki. So that film is was done on the Tourette syndrome. Okay, so you can see that, and also you can remember with the OCD and Tourette syndrome. And in the neurology, you will read it. It's very easy thing. Okay, let's go. I think OCD. What is the treatment for OCD? The fluoxetine, fluvoxamine, sertraline. So you need to know that.
SSRI.
Yes, SSRI, because it is related with the depression. By that way, you can remember it. Okay, very easily. Next, we can go for just read it. Dr. Vipasri, you can read it rapidly.
Yes, sir. A woman is continually worried that she may be contaminated with industrial chemicals in her workplace.
Yes.
She showers longer and longer every night to remove the chemicals. Timing her showers and always using a special towel afterwards. She works with cleaning products but has a normal level of contact with them, using them to clean floors. Which of the following is most likely to be effective in managing her symptoms? Amitriptyline, citalopram, L-dopa, pramipexole, sodium valproate. Sir, I think citalopram.
Yes.
SSRI.
Citalopram, citalopram, SSRIs. These are the important. Sometimes anyone can mistakes with the TCS because antidepressant, remember. So that's why you need to be confined with the medications also. Which one is SSRIs, which one is tricyclic antidepressants. You need to remember these differences. So pharmacology is very important here, okay? Otherwise, many of them know that this is OCD, but they will answer wrong because they don't know the classification of SSRIs. SSRI, the TCS, the benzodiazepines, there should be a list, anticonvulsants, antipsychotics, all list should be within your pads or papers, okay? Then it would be better because if you are reading whole medicine, you will make a mistake, must. That whether anticonvulsant, whether antidepressant, where is antipsychotic. I think this is another difficulty for the neurology and the psychiatric things. So that's why. Okay, now the alcohol. What is alcohol? What does do alcohol in our CNS? Just read it. I just read it for rapid hours. It increases GABA on its GABA receptor in brain, which causes open the chloride channel.
Right.
That is hyperpolarization brain cell causing depression of the CNS activity, and inhibit the glutamate action on NMDA receptors, leading to disruption of memory. So these two things, alcohol causing. Do you know these similar things causing by pharmacologically? That is benzodiazepine. This is similar, same mechanism of action. That's why in alcohol withdrawal syndrome, what is the treatment?
Benzodiazepine.
Yes, that's why benzodiazepine. So I think you will never forget because you will replace the alcohol with a medicine that is act same. So that's why benzodiazepine is a treatment of alcohol withdrawal symptom. Remember this for life. So alcohol withdrawal, the replacement of alcohol by a medicine, that is benzodiazepine. Similar medication, similar mechanism of action. So whenever you remember these things, you can remember benzodiazepine mechanism of action. Okay. So benzodiazepine, switch, lorazepam, diazepam, all of these things. You need to know the classification. Okay. So alcohol causing sedation, mostly sedation. If you just withdraw this alcohol, what will happen? Excitation. This alcohol causes CNS depressants, no? It causes depression. If you are not giving alcohol to that patient, suddenly a binge drinking patient, you are withdraw alcohol. So sympathetic activity will increase. You will rise with the glutamate and all other things rise. You will very excited. There's the features are alcohol withdrawal symptoms. So let's go with the alcohol withdrawal symptoms. Excitement. Mine means tachycardia, anxiety, agitation, tremor. So alcohol withdrawal symptom, just read it. Similar thing will be in the benzodiazepine withdrawal. Similar, mostly similar. But the hallucination will be little bit different and the history. So very easy. Alcohol withdrawal, there will be tremor, sweating, nausea, tachycardia, sympathetic all, psychomotor agitation, headache, insomnia. No sleeping. Visual hallucination, hair, auditory, tactile. You read the haptic hallucination? No, haptic names, no? That is, yes, tactile. That is tactile hallucination, that is haptic. So haptic hallucination is insect and parasites crawling with the beneath the skin. Insect beneath the skin. Insect beneath the skin, you should go for the alcohol withdrawal syndrome. Okay, only one symptom. You can diagnose it. And benzodiazepine withdrawal, same. Sympathetic activity will be occurs and hypersensitivity all occurs, visual hallucination occurs. So both are similar and both treatment is similar. Opiates, you should remember opiates. Opiates is mostly occurs with the GI symptoms, diarrhea. Patient will soil their clothes with the diarrhea. So there will be vomiting, diarrhea, all GI symptoms occurs with the lacrimations and all other things. Opiates are similar like pilocarpine crisis type, these things. So yawning, rhinorrhea, lacrimation, sweating, all sphincter will open. So this is opiates withdrawal syndrome. Withdrawal syndrome. So I think you can remember it with the pharmacology also, and you can read it with the psychiatry. So the alcohol withdrawal, there are some features. Like if you alcohol withdraw within days, that would be alcohol withdrawal symptom. That is tachycardia, agitation, visual hallucination. But if you withdraw it for 7 days, patient got disoriented. Patient will unconscious. So that is delirium tremens. Okay, hallucination, disorientation. So disorientation here is very important. Patient will be not conscious, unconscious. You will find a alcohol withdrawal patient unconscious. You will diagnose it is delirium tremens rapidly. Treatment same. You will go for the benzodiazepine and with the vitamin, thiamine. Okay, thiamine and these things. So how you can just go for this syndrome? Look, alcohol withdrawal symptom, there will be activity. Alcohol withdrawal is thought to lead to opposite. Decrease GABA, increase NMDA, glutamate transmission. Very important. And then there would be 6 to 12 hour tremor, sweating, tachycardia. Peak incidence seizures will be 36 hours. And delirium tremens, that is unconsciousness with the delusion hallucination, that is 40 to 72 hours. Usually 7 days also. So patient should be managed with the admission, hospital admission, and benzodiazepine, that is known as, most commonly here, you will find chlordiazepoxide. This is very important for your answer. Chlordiazepoxide. Repeatedly, you should read it, so that whether it is benzodiazepine or not, you should understand it. Then other things you can go. So this is a scenario of delirium tremens. I will not go for as lengthier. So you can read it. There is some hallucination, disorder, unconsciousness, but there is alcohol thing there that is present in the scenario. Patient is behavior disoriented behavior. So this is delirium tremens. Alcohol withdrawal symptom also you can find it here reading. By reading it, you can understand it. Now I am coming to post-traumatic stress disorder. This is very easy. A patient can go for abuse. A patient can go for the major disaster like accidents. So at that moment, there are some criteria of PTSD. What is this? PTSD, re-experience the nightmares, avoidance, that situation she should avoid it, and hyper-arousal, hyper-vigilant, very vigilant she is. She or he will not give you any chance. And there is still a sleep problem, emotional numbing they should be. So they should be treated, no? This treatment has some name, some therapies, that is EMDR therapy, eye desensitization therapy. There is some poor prognostic factor. You can just read it from here. The poor prognostic factor are these risk factors: duration of combat, low moral, poor. This is not so important, but you can read it. Management, you need to understand EMDR therapy. This is important. You will always write about the things that CBT, cognitive behavioral, but here the therapy is different. That is EMDR, eye movement desensitization and reprocessing therapy. I don't know what is this, but you need to remember it. As a medicine specialist, you need to remember it. This is a kind of treatment you need to give it. If it is not possible, in severe cases, you will give sertraline. Sertraline is the treatment. SSRI. There's SSRI will never ever be forbidden. So this should be given. So sertraline. Now you can understand this is a PTSD. If you read my lecture and you will find some question, you will be clear from your theory. Okay. So look, a fireman, I'm just reading it. A fireman presents with insomnia, recurrent bad dreams, depressive symptoms after witnessing death of his colleague during accident or incident they attended. There is some stress, no? Here is the inciting factor. So you understand that he was distressed at the time. He was unable to help his friend, had to withdraw from the building. Some guilt over there. He admits drinking glass of wine each evening helps sleep, violent, aggressive towards his girlfriend. Okay, is still suffering, missed significant amount of time of work. So this is kind of problem he is facing, that have some type of stress disorder. So this is PTSD.
So why not adjustment disorder?
Adjustment is actually the benign disorder. Adjustment disorder is a benign disorder. Adjustment is you are not staying with your colleague because you don't like him. It's like that. That is one kind of phobia type disorder, or minimum, that is not so much a stressful disorder, because in adjustment disorder there will be no incident, but in PTSD there would be an incident. What is the incident here?
Traumatic experience.
Trauma, yes, traumatic experience. That's why. Okay, adjustment disorder is benign thing. I will not adjust with him, never, ever, just like that. But PTSD, there will be trauma. This is important. Okay, I think it's easier. That's why I'm going little bit speedy. Now you know this is also PTSD. EMDR therapy you can give. Oh no, here EMDR is present, but EMDR is not the answer, because here list evidence. I just give it to read the lecture, to read the question very clearly. Sometimes you can find list evidence. That's why I'm providing it. List means minimum. That is not helpful. That is not helpful. So in PTSD, all are the helpful. Which one is helpful? SSRI is helpful. PCBT, these are helpful. No, I think the benzodiazepine also helpful. Mirtazapine is not helpful. I think. Which one is answer? I don't know. No, benzodiazepine. Benzodiazepine is not helpful. Mirtazapine is SSRI. Sorry, it is SSRI. That's why you need to know. So it is not helpful. BDZ is not helpful. So list is important. That's why pharmacology is important also. Now we can go for postpartum problem. There are few problems very easy to understand. Postpartum blues, baby blues, postnatal depression, psychosis. This depends on which thing, that is days only days and weeks. You should remember the days and weeks. Then the all other things are same. A postpartum blue, baby blues, patient 3 to 7 days following the birth. Within the 3 to 7 days, patient will suffer from depression. Okay, anxious, tearful, irritable. So reassurance. This is benign one. But which one is dangerous? This is psychosis term is dangerous. Danger. There is the hallucination. Whenever psychosis, you know now that it is delusion and hallucination would be there. So this is dangerous, and it is after 2 to 3 weeks. Duration is important. After 2 to 3 weeks, and within 3 months, within a month, it can happen postnatal depression, major depression, that is depressed, low mood, loss of energy, psychomotor agitation, R for that is reluctant to feed, depression, E for energy loss. So depressed, I have give you mnemonics of depression. That depressed, you can just remember the major depression. So that is postnatal depression. So very easy, postpartum blue, natal depression, psychosis. You can understand. So now read it, please, rapidly. We are in the finishing part of our lecture.
7-year-old female.
Yes, louder.
Yeah, who gave birth to a baby boy 5 days previously. Reports that she is fearful, anxious, and emotionally lethargic. When questioned, she says that although her sleep is disturbed by the baby waking in the night, she is otherwise sleeping, eating well, and has no ideas of self-harm or suicide. She comes back the following week and says she feels much better. The baby
Only
blues.
3 to 5
Baby
days, no? Benign, yes, benign one. Very nice, baby blue. I am not, I think everyone understand now. This is baby blue. No, that is postpartum blues. Okay, very benign one. 3 to 5 days, patient having no lack of sleep. That's why baby blues. Now this one, read it rapidly.
31-year-old woman seen at home by her GP, 12 weeks postpartum. She is fearful, has lost her appetite, and fears that she is worthless and will never amount to anything again. There are no pictures of delirium. She has a history of illicit drug use, and her old brother had depression. There are no features to suggest infection, and there are no focal neurological signs. Postpartum depression.
Postpartum depression.
Very nice. You find the depression symptoms, lost her appetite, worthless, family history of depression. No, all are the put the major depression also. So postpartum depression. And the days, 12 weeks. So within 3 months.
3 months.
That is also duration and the symptom. Both are the very important. Now this one last. Rapidly read it.
A 40-year-old woman is referred by the community midwife to general practice with checkups of mood change 1 week after the birth of a baby. She is very tearful and crying, does not want the child, and tells the GP that it is dying. She has some auditory and visual hallucinations, with the auditory hallucinations instructing her to harm herself. Which of the following is the most likely diagnosis?
Psychosis.
I think it's clear.
Yeah,
Very easy.
Yeah.
Now you know the psychosis means hallucination, delusion, all are the things. Okay, very nice. So I think all of you will read about the pharmacology and all other things. Okay. The sleep paralysis.